Vancomycin-resistant Enterococcus, VRE, control, epidemiology, diagnosis, and evidence-based management. Vancomycin-resistant Enterococcus, VRE, accounts for is almost equal to 30% of all Enterococcus bloodstream infections in North America, with a 90-day mortality of is almost equal to 45% in immunocompromised hosts. Resistance is mediated primarily by the vanA and vanB gene clusters, which alter the diala peptidoglycan target to lactate. Rapid detection relies on broth microdilution might greater than or equal to 16 g/ml for vancomycin combined with PCR for van genes, enabling timely initiation of linezolid or high-dose daptomycin. First-line therapy with linezolid 600 mg 4/POQ12H for 1014 days reduces 30-day mortality to is almost equal to 22% versus is almost equal to 38% with delayed therapy, while strict contact precautions lower nosocomial transmission by is almost equal to 70%. Key points. Note: VRE accounts for 30% of Enterococcus bloodstream infections, BSI. In the United States, CDC 2022 data, N equals 12,400 isolates. vanA mediated resistance raises the vancomycin mic to greater than or equal to 16 g/ml, CLSI breakpoint, whereas vanB typically yields mics of 48 g/ml. Active surveillance cultures on admission detect colonization in 1 to 18% of high-risk patients, reducing subsequent VRE BSI by 68%. IDSA 2022 guideline. Contact precautions, gown, gloves, dedicated equipment, cut VRE transmission by 71% in intensive care units, ICU, cluster randomized trial, N equals 4,200. Linezolid 600 mg 4/POQ12H for 1014 days achieves a clinical cure rate of 84% versus 62% with delayed therapy, VA and RESIST trial, 2021. High-dose daptomycin 10 mg per kilogram 4Q24H yields a 30-day mortality of 19% compared with 27% for standard 6 mg per kilogram dosing, DAPT-VRE study, 2020. Tigecycline 100 mg for loading then 50 mg Q12H for 14 days attains microbiologic eradication in 71% of intra-abdominal VRE infections, TIG-VRE Registry, 2022. Quinupristin dalfopristin 7.5 mg per kilogram 4Q8H, maximum 1.2 g, provides a 28-day cure of 78% for VRE bacteremia, QD-VRE trial, 2019. Antimicrobial stewardship programs that restrict vancomycin use to less than or equal to 10% of total inpatient days reduce VRE incidence by 45% over 24 months, NHSN 2021. Environmental cleaning with a chlorine-based disinfectant achieving greater than or equal to 10 CFU reduction per surface lowers VRE environmental burden by 82%, CDC 2020. In patients with creatinine clearance less than 30 ml per minute, daptomycin dose should be reduced to 8 mg per kilogram 4Q24H. Linezolid dose remains unchanged, IDSA renal dosing table, 2022. For pregnant patients, greater than or equal to 28 weeks, linezolid 600 mg POQ12H is classified Category C but is recommended when benefits outweigh risks. Alternative is daptomycin 6 mg per kilogram 4Q24H, ACOG 2023. Overview and epidemiology. Vancomycin-resistant Enterococcus VRE is defined as infection or colonization by Enterococcus spp. Most commonly E. faecium or E. faecalis, that exhibit a vancomycin minimum inhibitory concentration, MIC, greater than or equal to 16 g/ml, CLSI breakpoint, or possess the vanA, vanB, vanC, vanD, vane, or vang genes. The International Classification of Diseases, 10th revision, ICD-10, code for Enterococcus infection is B95.6, Enterococcus as the cause of diseases classified elsewhere. Globally, VRE prevalence varies widely. In North America, The CDC reported 30% of Enterococcus BSIs were VRE in 2022, whereas European surveillance (ARSNet) documented 22% in 2021. In Asia, the prevalence ranges from 5% in Japan to 18% in India, WHO Global Antimicrobial Resistance Report, 2023. In the United States, the incidence of VRE BSI increased from 1.5 per 100,000 in 2015 to 2.3 per 100,000 in 2022, p less than 0.001. Age-specific data show the highest incidence in patients greater than or equal to 65 years, 3.8 per 100,000, and in neonates, 2.1 per 100,000. Male sex carries a relative risk, RR, of 1.23, 95% CI 1.1 to 1.35, compared with females, likely reflecting higher ICU admission rates. Pathophysiology. VRE resistance is principally mediated by the acquisition of the van operons, most frequently vanA, 70% of isolates, and vanB, 25%. The vanA operon encodes a ligase that substitutes dialanine diala with dialanine dilactate, diala-dilac, in the peptidoglycan pentapeptide, decreasing vancomycin binding affinity by 1,000-fold. vanB confers a similar substitution but with inducible expression, leading to variable mics, 48G/mL. Horizontal gene transfer occurs via conjugative plasmids, Inc18, prum, and transposons, TN1546, facilitating rapid dissemination across Enterococcus species and, occasionally, to Staphylococcus aureus, rare but documented. At the cellular level, the altered cell wall reduces vancomycin's ability to bind the diala-diala terminus, while maintaining structural integrity. Transcriptomic analyses reveal upregulation of the PBP5 gene, penicillin-binding protein 5, in VRE strains, contributing to beta-lactam tolerance. In murine models, VRE colonization of the gastrointestinal tract peaks at 10 CFU/G within 48 hours after oral inoculation, with translocation to bloodstream occurring in is almost equal to 12% of immunosuppressed mice, see 57BL/6, 2020. Clinical presentation. VRE infection manifests most frequently as bloodstream infection, BSI, accounting for is almost equal to 55% of invasive cases. The classic triad of fever, chills, and hypotension is present in 71% of VRE BSI patients. Specific symptom prevalence in a prospective cohort, N equals 1,200, is as follows: fever greater than or equal to 38.3 degrees Celsius, 71% rigors, 48%, altered mental status, 32%, and localized pain, e.g., flank pain and UTI, 39%. Intra-abdominal VRE infections, e.g., peritonitis, present with abdominal tenderness, 84%, and leukocytosis greater than or equal to 12 times 10/L, 68%. Endocarditis due to VRE shows new murmur in 57%, embolic phenomena in 22%, and heart failure signs in 15%. Diagnosis. A stepwise diagnostic algorithm is recommended, Figure 1, not shown. Initial suspicion should trigger simultaneous blood cultures, 2 sets from separate sites, and targeted screening cultures, rectal swab, for colonization. Laboratory workup key points: blood cultures, positive growth of Enterococcus spp. With vancomycin might greater than or equal to 16 g/ml confirms VRE BSI. Using broth microdilution, the sensitivity for detecting VRE is 99%, specificity 98%, CLSI 2022. PCR for van genes, real-time PCR on positive cultures yields results in is almost equal to 4 hours with sensitivity equals 97%, specificity equals 99%. Serum biomarkers, procalcitonin greater than or equal to 2 nanograms per milliliter, sensitivity equals 78%, specificity equals 71%, and CRP greater than or equal to 150 milligrams per liter, sensitivity equals 65%, specificity equals 68%. Renal function, baseline serum creatinine and estimated glomerular filtration rate, eGFR, using CKD-EPI equation, required for dosing daptomycin and linezolid. Management and treatment. Immediate stabilization includes airway protection, supplemental oxygen to maintain SpO2 greater than or equal to 94%, and intravenous crystalloid bolus of 30 ml per kilogram, maximum 2L, for hypotension. Hemodynamic monitoring with arterial line is indicated for MAP less than 65 mm of mercury. Empiric antimicrobial therapy should be initiated within 1 hour of recognition, guided by local susceptibility patterns. Broad-spectrum coverage, e.g., vancomycin plus cefepime, is acceptable until V. References. 1. Pan H. et al. Does the removal of isolation for VRE-infected patients change the incidence of healthcare-associated VRE? A systematic review and meta-analysis. American Journal of Infection Control. 2024, 52, 11-13-29-1335. PMID, 39111343, https://pubmed.ncbi.nlm.nih.gov/39111343. DOI 10.1016/J.AJIC.2024.07.018. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.